this opportunity. We take this as an opportunity to announce that we have recently launched BDFC, Belt Road Diabetic Foot Clinic. With the BDFC, we plan to move an advanced facility for wound healing like VAC, HBOT, and microvascular surgeries capabilities. And there will be a small glimpse. Thank you. And BDFC is located at Raja Annamalapuram Bedrotha Hospital. It's our branch hospital there. And we request our chairperson, Dr. Paneerselvam, who completed his MBBS from Chengalpattu Medical College, MD General Medicine from Stanley Medical College, and chairman of various insulin banks, and co-chairman of Diabetic Association India South Indian Chapter, managing trustee of Aruna Diabetic Research Foundation, Chennai. And there is a special note. We have insulin stocked in and around all the government hospitals only because of sir. Sir, welcome so much. I request you to deliver your speech, sir.
Good evening to all of you. So I am happy Bedrotha Hospital is organizing a CME on diabetic food. Of course, many senior people may be knowing how the Bedrotha Hospital evolved. So how Dr. Jagannathan was struggling earlier, 40 years before as general practitioner. Then he started his hospital and it has come to this level. Very happy. So I am also going there as a consultant. I used to admit my cases. And Dr. Bablo is my diabetic foot surgeon after Dr. N. Mohan. Earlier during 90s, Dr. Mohan was helping me and Dr. Muthu was helping. Of course, regarding diabetes, all of us are aware. Diabetes is a growing epidemic all over the world. I used to tell the International Diabetes Federation, that is, International Diabetes Federation is a global body for diabetes. It has a link with the United Nations as well as the WHO. This International Diabetes Federation is collecting information all over the world regarding diabetes and interact with the United Nations as well as WHO and pass on the message to the concerned countries. Despite this effort for more than 30-35 years, still the diabetes is on increase. So leprosy without vaccine, we have drastically brought it down. AIDS without vaccine, we have drastically brought it down. All waterborne diseases like cholera, typhoid, etc. also came down. And with the vaccine, of course, smallpox and polio got eradicated. But unfortunately, diabetes is still on increase. Whatever effort we take all over the world, it is keep on increasing. Not only that, earlier it was criticized as diabetes single disease specialty. While I did my diploma diabetology in MMC, 89, my own teacher who taught me MD General Medicine, no, I thought you might enter into cardiology or neurology. Why you have come to diabetes? Diabetes is single disease specialty. What is there in diabetes? Plain and lenti insulin plus dianyl and metformin, classified tablet. Only these only. Now everybody is practicing diabetes all over India. So 30-40 years before, hardly we had 30 diabetologists in country. After that, after 10 years, 300 diabetologists. Now we have sensitized all doctors all over India to certain extent regarding diabetes. Despite all these things, still the disease is going on. Not only the disease is going on, the complication rate also going on. So as a medical professional, what we should do? The upcoming doctors, 22 years, 23 years, MBBS, recently finished, or the senior most consultant in the diabetes or endocrinology or cardiology, or the senior most practitioner, 80 years, 90 years, 40 years, 45 years of practice, everybody is struggling with diabetic cases now. So the message for all the practitioners now, and we tell the WHO as well as the International Diabetes Federation and our own scientific body in diabetes also. So we have to start preventing diabetes. Primordial prevention is possible now. What do you mean by primordial prevention? We have to prevent diabetes in utero. Now gestational diabetes is also on increase. So for gestational diabetes mellitus, Dr. Sheshaya has worked for 40 years. We also worked along with him for more than 35 years. So during pregnancy, asymptomatic hyperglycemia translates to fetus. Fetal beta cells are stimulated. Fetal hyperinsulinemia. It grabs more glucose from the mother's circulation. Then after delivery, macrosomia, or during adolescence, obesity, insulin resistance. Before the age of 20, the children born to diabetic mother becoming insulin resistant or pre-diabetic or frank diabetic. Otherwise, we have to identify diabetes early during pregnancy, or we have to screen all pregnant women. Unfortunately, for the past 10 or 15 years, even before pregnancy itself, many women are insulin resistant, pre-diabetic and diabetic. This is another sorry state of affair. Because of lack of physical activity, consuming more of energy-dense diet, and sitting in front of TV, cell phone or computer, or screen time. So in front of screen, any screen, whether it is cell phone screen or TV screen or computer screen, we sit in the front of screen for many time and consume energy-dense diet. Many young adolescent boys and girls are becoming obese and insulin resistant or pre-diabetic. So before pregnancy itself, they are diabetic. During pregnancy, in presence of hyperglycemia, they get conceived. Then after 15-20 years, the problem is going to be multiple if you don't intervene. So no other go, we have to sensitize the so-called health planners and administrators. We keep on hitting at their head, but unfortunately, they have opened their eyes. 20 years before they were snoring, not sleeping. Now only they have opened their eyes and started declaring program and NCDs and started screening for diabetes. Of course, screening is helping. They are identifying the new cases and uncontrolled cases, but still uncontrolled case is prevailing despite Makkalai Thedi Maruthuvam. Still the complication rate also going on increasing. So the message, we have to concentrate during pregnancy, we have to prevent diabetes during pregnancy. Then after the age of 20 or at least after the age of 30, every individual in India should undergo screening annually. So annually we are celebrating birthday, marriage day, or Deepavali, Pongal, or Christmas, etc. Can't they spare few minutes to get screened for diabetes, hypertension, lipids, and obesity? Otherwise, I call this as whole disorders: hypertension, obesity, lipids, and diabetes. So after the age of 30, all parameters are normal. Let us encourage them to hold them normal. If some parameters are abnormal, correct them towards normal with the help of diet and exercise, and the primary care physician, the so-called general practitioners, or whatever the practitioners, and maintain the normalcy. Even if they develop clinical diabetes, we can identify diabetes very early, because 30-40 years before meters were not available. Facilities were not available. Literacy rate was poor. Your per capita income also less. Now literacy rate improved, per capita rate also improved, and your cell phone usage is high. Despite all these things, still we allow the disease to grow. So better to identify cases early and revert them back to normal, maintain the normalcy. If you attempt like that, definitely, drastically we can reduce the complications, including today's topic, diabetic foot. Not only diabetic foot, we all know the complication is all over body, because blood goes everywhere. Excess sugar also will go everywhere. From your cerebrovascular accident to your retinopathy, cardiomyopathy, or infarction, nephropathy, or neuropathy, or peripheral vascular disease. So all complications, all of us are aware. So to reduce the quantum of diabetic, we have to concentrate as a practitioner to prevent diabetes during pregnancy and identify diabetes around the age of 20 to 30, sensitize the entire population towards normal level, how to maintain the normalcy, then what are all the ways how to treat. For practitioners also, if you are not in a position to control, kindly guide the patient. Unfortunately, for 5 to 10 years, same drugs are getting repeated with fasting blood sugar 250, post-prandial 280 or 300, A1C more than 8. Such attitude we should not have first. We should help the patient, guide the patient towards good control. What do you mean by good control? Before food less than 110, after food less than 160. A1C once in 3 months or at least once in 4 months should be less than 7. 6.5 is ideal. If it is so, definitely 90% of the complications can be avoided. 90 to 95% of the complications. So with this small introduction about diabetes and our role as a practitioner for future diabetics, so we have to reduce the complications. So let me invite today's first topic by Dr. Monica, isn't so? So Monica, biodata, will you read?
Yes, sir. I will read, sir.
Right.
Thank you, sir.
So over to first topic today, because Dr. Bablo will talk later. Antibiotic stewardship in the diabetic foot infection. So let us listen to her lecture. Then we'll have discussion at the end of all the 4 topics. Thank you.
Yeah. Thank you, sir. Thanks for briefing us. Dr. Monica, ma'am, she completed her MBBS from Madurai Medical College, MD from Stanley Medical College, MRCP and London University, fellowship in general infectious diseases. Ma'am passed her UG and PG in distinction. Her case presentation and research article done at Tamil Nadu Association of Physicians of Indian Conference and Indian Society of Nephrology Southern Chapter won various prizes. Her area of interest are infectious disease and diabetic management and chronic disease management. Please, ma'am.
Stewardship in diabetic foot infections. So as the picture depicts, we are in an era of antibiotic resistance. We are in fact running short of antibiotics, so it's high time for antibiotic stewardship, and hence today I'll be restricting my topic only to antibiotic stewardship in diabetic foot infections. As we all know, DFI is a chronic complication which affects around 15% of the people with diabetes. So treatment often encompasses a broader than necessary antibiotic, hence this leads to antibiotic misuse. So we clinicians, we often prescribe antibiotics expecting that it will prevent the infection and promote the wound healing even if the ulcer is not infected, but actually there is no evidence to support this assumption. Hence, overuse of this antibiotic in fact leads to a lot of adverse effects, antibiotic resistance and cost. Therefore, antibiotic stewardship programs in diabetic foot infections are really warranted. So let's move on to our case number 1. So first of all, the objectives of my talk are mainly to classify diabetic foot infection and the appropriate method of sample collection for culture and the best antibiotic practice for managing diabetic foot infection. So this is our case number 1. She's a 60-year-old female, known case of diabetes mellitus on OHA. She presented with complaints of pain and swelling in right second toe with purulent discharge for the past 5 days. On examination, her vitals were normal. Her general and systemic examination were unremarkable. And local examination revealed swelling, redness, and a small ulcer with purulent discharge in the right second toe. So these are our labs. Total count is marginally elevated, 13,900 with a CRP of 8.9, and the sugars are not under control with a HbA1c of 8.9. So this is a picture. So what next? So first, before we go on to the management of diabetic foot infection, first of all, I would like to go by a stepwise approach. We first need to know what is the organism, first of all, which is causing this diabetic foot infection. Then we need to assess the severity and classify it. And then we have to collect the appropriate specimen for culture and start on empirical antibiotic regimen and take a call on the surgery. So first on the microbiology, these are the etiology of diabetic foot infections. Cellulitis is most commonly caused by beta hemolytic streptococci and Staph aureus. If it's an infected ulcer, which is antibiotic naive, it's most often monomicrobial, Staph aureus or streptococci. In case the ulcer is chronic with a history of previous antibiotic therapy, you need to think about polymicrobial infection, namely Staph aureus, streptococci, in addition Enterobacteriaceae, namely E. coli, Klebsiella, etc. In case the ulcer is macerated, there is a risk of Pseudomonas in addition to other infection, other organisms. If it's a long-standing, non-healing wound with prolonged antibiotic therapy, you have to think of polymicrobial infection with antibiotic-resistant organisms like MRSA, ESBL organisms, ESBL E. coli, enterococci, pseudomonas, fungus, etc. And if it's a fetid food with extensive necrosis and gangrene, then it's usually a mixture of mixed aerobic and anaerobic. So let me repeat it. If it's cellulitis, it's a streptococci or staph aureus. And if it's antibiotic naive ulcer, it's the same organism. And if there is history of previous antibiotic therapy, it's polymicrobial. And if it's a macerated ulcer, think of Pseudomonas. And if it's a long-standing, non-healing wound with prolonged antibiotic therapy, you have to think of the resistant organisms. And if it's a necrotic, gangrenous food, then you'll have to think of mixture of both aerobic and anaerobic. So next step, having known the microbiology, we need to assess the severity. So this assessing the severity, it will help us in determining the need for hospitalization, the choice of antibiotic therapy, and the need and the timing for surgery, and also the possibility of amputation. So the International Working Group on Diabetic Food and Infectious Diseases Society of America, they have established a criteria to assess the severity of diabetic foot infection. So this is the most important slide, the classification which has been put forth by the IDSA. So it's a class 1 infection. It's uninfected if there are no symptoms or signs of infection, it's class 1. Class 2 is mild infection if the infection involves only the skin and subcutaneous tissue and at least 2 of the following items like local swelling or induration, if the erythema is around 0.5 to 2 centimeter, or if there is tenderness or pain, local warmth and purulent discharge. Only if 2 of these items are present, then we can call it's infected. But before we come to a conclusion, we need to rule out other inflammatory causes like Charcot's gout, because they are also present with similar kind of signs. So this is mild infection. Next is moderate infection, which is class 3. Moderate infection, the erythema will be more than 2 centimeter in addition to the signs and symptoms of infection which I've already mentioned. And if the infection involves structure deeper to the skin and subcutaneous tissue like abscess, fasciitis, osteomyelitis, and septic arthritis. Severe infection is class 4, which is nothing but moderate infection with presence of systemic inflammatory response syndrome, namely like fever, hypothermia, tachycardia, tachypnea, and leukocytosis or leukopenia or Bank cells more than 10%. So this is the most important classification. Class 1 is uninfected. Class 2 is a mild infection involving only the superficial tissues with erythema of 0.5 to 2 centimeter, and moderate is erythema more than 2 centimeter with deeper involvement of the structures. Signs and symptoms may be absent. So in this scenario, you need to look for alternative signs like purulent discharge, if there's a fetid odor, necrosis, poor granulation tissue, undermining of the wound edges, and lack of wound healing. These all point to the signs of infection. And in addition, serum inflammatory markers like total count, ESR, CRP, and procalcitonin may be helpful. So having classified, next we need to take the specimen for culture. So bacteria culture is routinely not recommended for uninfected wounds. And as we all know, most of the mild acute infections which have not been treated with antibiotics are caused by either Staph aureus or hemolytic streptococci. So cultures may be unnecessary in these cases. And it's always recommended to take the sample before initiating antimicrobial therapy. And the most important point, superficial swab specimens are not recommended for culture. It gets contaminated with the skin commensals. and the overlying necrotic debris should be removed before culturing. And we need to rule out osteomyelitis by the probe to bone testing and imaging. So this is the IDSA guidelines on specimen collection. So you need to cleanse and debride the wound before obtaining the specimen. And a tissue specimen is always recommended by scraping with a sterile scalpel or a curette, or a biopsy from the base of the ulcer, and aspirate any purulent secretion using a sterile needle or a syringe, and promptly send the specimen in a sterile container or a transport media. And do not culture any clinically uninfected wound unless it's indicated for epidemiological purpose, and do not obtain a specimen without cleansing or debriding the wound, and do not obtain the specimen by just superficial swabbing. Okay. So back to our case. So ours comes under a mild infection. It's class 2. It's an antibiotic naive ulcer. So most often it's monomicrobial, either Staph aureus or Streptococcus. So culture might be unnecessary. So how do we proceed? Next we go on to the treatment. So I'll just elaborate about the approach to treat diabetic foot infection. So as we all know, effective management of diabetic foot infection requires a multidisciplinary approach. Appropriate antibiotic therapy, surgical drainage with debridement, appropriate wound care, and most important, improved glycemic control and assessment of the vascular status. So we need to select an antibiotic based on the likely or proven causative pathogen, the clinical severity of the infection, and the efficacy of the agent, and having in mind of the risk of adverse effects and the financial cost. So I would like to introduce few terminologies before going on to the empirical regimen. So these are the risk factors for polymicrobial infection, namely chronic ulcer and history of previous antibiotic use, ischemia, necrosis or gangrene, and the risk factor for MRSA when the patient has recently received antibiotic therapy, having previously hospitalized, prior MRSA infection, nasal carriage of MRSA, chronic ulcers. These are risk factors for MRSA. And anaerobic infection, you need to suspect if it's a deep chronic ulcer with ischemia, necrosis or gangrene, and if there is foul smelling fetid discharge. And Pseudomonas, most important, it's not very common in temperate climates, but in warm climate like India, it is common with frequent exposure to water, macerated wounds, and high local prevalence of Pseudomonas. You need to suspect Pseudomonas. These are the risk factors. So let's move on to the empirical antibiotic regimens. So I've just summarized based on our clinical practice, which are all the antibiotics to be used. So if it's a non-infected ulcer, no antibiotic. And if it's a mild infection, you can prefer oral route. Preferably, you can just start with flucloxacillin or dicloxacillin 500 milligram QID dose, or cephalexin 500 milligram QID, or any first generation cephalosporin for the case, amoxicillin, clavulin, and clindamycin. If there is risk of MRSA in a patient with mild infection, you can start with either doxycycline 100 twice a day, or cotrimoxazole, which is double strength twice a day. So this is the empirical antibiotic regimen for mild infection, which can be treated as an outpatient. So next is a moderate infection. It could be treated either parenterally or orally. So based on the risk factors for polymicrobial infection, if the risk factors are absent, you can start with cefazolin 1 to 2 gram IV TID, or any second or third generation cephalosporin like ceftriaxone 2 gram IV OD, ampicillin sulbactam 3 gram IV QID, or fluoroquinolones, Livaflox or Moxiflox, either oral or IV. In case the risk factors for polymicrobial infections are present, the risk factors which I have already mentioned, then you need to start with piperacillin tazobactam 4.5 gram IV QID, or etapinum 1 gram IV OD, or ceftazidime or cefepime 2 gram IV TID. If there is evidence of ischemia or necrosis or gas forming organisms, then you need to add clindamycin 600 to 900 milligram TID, or metronidazole 500 milligram TID, And if there is MRSA, you can add vancomycin, 15 milligram per kg, twice a day dose, or linezolid or daptomycin. So if the patient is having severe infection, we prefer parenteral route. I'd start with the carbapenem, imipenem celastin 500 milligram QID, meropenem 1 to 2 gram IV TID, piperacillin tazobactam or tigecycline. In addition, patient might need MRSA coverage plus or minus clindamycin. And special mention about necrotizing fasciitis, I would start the patient either on piperacillin tazobactam or carbapenem. Most often the patient will be sick because it's a very rapidly progressive infection caused by flesh-eating bacteria. In addition, MRSA coverage with vancomycin or linezolid or teicoplanin with clindamycin. Osteomyelitis, I don't want to go into detail, it's a very huge, vast topic. The duration, we just said, based on the local prevalence of organisms and whether it's community acquired or hospital acquired, we need to start on the empirical antibiotic regimen. And then about the duration. So duration is often guided by the clinical response, with shorter courses sufficient for quick to respond infections. The cellulitis, 1 to 2 weeks. For mild infection, 1 week. If necessary, you can extend it to 2 weeks if it doesn't resolve. And moderate infection, 1 to 3 weeks. And for severe, it's often 2 to 4 weeks. Osteomyelitis is present 6 weeks. Maybe you can start with 2 weeks of parenteral therapy, and if the patient has started to respond, you can switch over to oral therapy. And most important, use oral antibiotic as much as possible and consider de-escalation wherever possible. And discontinuation is always should be considered when the signs and symptoms of infection has resolved, even if the wound has not completely healed. So moving on to our case number 1, can anyone please suggest what antibiotic would you start this patient on? It was a mild infection, most monomicrobial. So you can start with, fluoxetine or augmentin or cefalexin of your choice, and most important, glycemic control. You can start with 5 to 7 days and then review the patient. If the infection is resolved, if only there is wound, then it's not necessary to extend the antibiotic, just for the case of wound healing. So next, our case number 2. A 54-year-old male, no diabetic or no OHA, presented with pain and swelling of left foot, was treated by general practitioner as outpatient for similar complaints 1 month back with antibiotics. Now developed worsening pain, swelling and discoloration for past 1 week. On examination, patient was hypotensive with BP of 90-60, pulse rate 110 and 100-degree temperature with a respiratory rate of 30. Patient was febrile tachypneic and there were bilateral scattered crepitations. Local examination, there was a swelling, redness of the left foot with blackish discoloration which was extending to the sole. Distal pulses were palpable. So these are the labs. Total counts are elevated, CRP is pretty high, and creatinine is marginally elevated, possible AKI, and HbA1c is very high. Sugars are like uncontrolled hyperglycemia. HbA1c was 10.1 with ketones were positive. And this is a picture. So based on my talk, can anyone please suggest how do we go about? First of all, the diagnosis. What is the class of the infection? It's a class 4 infection because patient has the signs of systemic inflammatory syndrome. So it's a sepsis with AKI and uncontrolled hyperglycemia. So it's organisms causing? It's mono or polymicrobial? Yeah, it's polymicrobial. And there is a risk of MRSA because patient has already had a history of antibiotic use in the previously, and there is necrosis, hence anaerobic infection risk is there. So what would you do? Admit the patient, culture appropriately. The tissue culture is recommended after debriding the wound, and glycemic control with insulin, correct the metabolic derangement, and empirical regimen. The patient is in sepsis, septic shock. It's a class 4 infection. What would you start the patient on? Okay. Linezolid for MRSA coverage. And then? Yes. Either imipenem or meropenem with clindamycin with plus or minus clindamycin. And then obviously surgery. Patient needs surgical debridement. So these are the key recommendations by the International Working Group of Diabetic Foods. So I've just summarized the recommendations which are relevant to my topic. So always diagnose an infection clinically and assess the severity using the IDSA classification. An appropriate method of sampling by curettage or biopsy. Superficial swab specimen is not recommended. And treat the patients with oral antibiotics and consider de-escalation as early as possible. Rule out osteomyelitis. And the most notable update is compared to 2012 guidelines is they've reduced the duration of the antibiotic therapy to 10 days in patients who have undergone debridement. And select appropriate antibiotic with right dosing and duration. I've seen a lot of prescriptions with clinicians who start piperacillin, tazobactam, 4.5 gram BD. It's a very suboptimal dose. One thing, patient is not going to improve, and this is also going to increase the emergence of resistance. So optimal dosing and duration. Do not undertreat or do not overtreat. And do not use currently available topical antimicrobial agent. IDSA actually recommends against the use of topical antimicrobials because the studies are lacking. And empirical treatment against Pseudomonas is usually not necessary, but if it can be considered in tropical climates with history of frequent exposure to water. And do not treat an uninfected foot ulcer with antibiotic with the goal of reducing the risk of infection and promoting ulcer healing. And prompt surgical consultation, which is the cornerstone of treatment of diabetic foot infection. So wind up with the last case number 3, a 56-year-old male presented with the complaints of ulcer and amputated right foot for 1 month with no pain or discharge. Patient is a known case of diabetic for the past 15 years on insulin and history of right forefoot amputation 2 months back following trauma. On examination, vitals were normal, systemic examination was unremarkable. And there was a 2 centimeter ulcer in the dorsum of right foot with clean edges. So these are the labs. Counts are normal. CRP is also fine. HbA1c, sugars are under control. So wound culture showed cornybacterium. So this is the picture. So what's the diagnosis? What class? What's the class of infection? It's a non-infected ulcer post-amputation. As I already mentioned, there's a clean edges, there were no pain or discharge, there's no evidence, there's no sign of inflammation. So it's a non-infected ulcer post-amputation. So how would you go about? No antibiotic. So treat the patient and not the culture. The culture is cornybacterium is the most common skin commensal which has been isolated. So this is the last slide. The novel antibiotics are being studied for the treatment of diabetic foot infections. Of these, cefiderocol and dalbavancin have been extensively studied for diabetic foot infection and they have proved promising results. So these are my references. Thank you. Protect the antibiotics for the future. Thank you.
Thank you, doctor. She has very well dealt with infection, diabetic foot ulcer with 3 cases. So we will have discussion at the end. Now the artificial intelligence in diabetes care by Dr. N. Wasim Ahmed. Of course, artificial intelligence is again a growing topic all over the world. Our smartphone are all under artificial intelligence based only. Now they are applying in the clinical medicine also. Of course, in clinical medicine, as we all know, we cannot totally apply artificial intelligence in clinical medicine. One case I will give. So during my PG days, in the OP we have seen one case with the 590 blood sugar. We have given plain insulin during those days, annual insulin, 80s. So 10 units subcutaneous and send the patient to the ward for admission. While we went and saw the patient by 11:30, patient was in hypoglycemia. So drowsy, etc. So we do not know which patient, because artificial intelligence will calculate as per the blood sugar and as per the age, weight, etc. But as per that, if you proceed, so sometimes we may land up with a problem. So clinical medicine is slightly different. For example, hurriedly both the kids may be taking, one kid may be obese and another kid may be lean. So artificial intelligence to set next thing we can apply in clinical medicine. Of course, let us listen to Dr. Wasim of how the artificial intelligence is helping in clinical medicine as well as in diabetes.
Dr. Wasim Ahmed, our consultant physician and diabetologist at R.A. Belroth Hospital. Sir completed his MBBS from Tanjore Medical College and DNB from Lahore Hospitals, Kochi. Sir's area of interest are comprehensive type 2 diabetes management, gestational diabetes management, and chronic disease management such as hypertension, thyroid dysfunction, dyslipidemia, etc. Geriatrics and food care are his area of interest.
Okay, thank you Dean Belroth and all the delegates today for attending today's CME. So my topic is on artificial intelligence in diabetes care. So if you could see here, the artificial intelligence is not something very new. It has been there from 1940s and 1950s. And the first chatbot came in 1960s. Its name is Elisa. Nobody knows that. But even the recent days is what it came into the limelight, that through chat GPT and other chatbots. So in AI, you have so many subsets, no? And you can see the evolution of this AI through the development of the insulin pumps through Medtronics. As you could see here, the Medtronic company has been developing the insulin pumps, refining its its work and the technology behind it. It's been updated on almost every 5 years. You can expect something new from the Medtronics team. So artificial intelligence is a broad spectrum and it comprises of machine learning, deep learning and generative AI. So what is artificial intelligence basically? It actually takes into consideration the information which we give. It learns regarding it, takes decisions and brings in solutions to complex problems. So inside that we have machine learning as a subcomponent, in which you have the machines taking care of the information, preparing algorithms and delivering the data. Next thing is deep learning. It actually works almost like a human brain, where the information is categorized, stratified. It removes the unnecessary data, takes into consideration only necessary data, and it gives the output. Third thing is the generative AI, where you can generate information. For example, you can convert images to texts, text to images. All these things can be done. So basically, what are we targeting? What is our intention behind using all these AI? Eventually, it's to prevent these events on the right hand side, all the complications and all that. And how do we do that? We prevent through various timely strategies, early diagnosis, properly managing and providing good care. And who are the beneficiaries regarding the AI? Patients with diabetes, the healthcare professionals and the entire healthcare system. All of them are going to benefit by using AI in a proper manner. So AI is basically, in the recent days, it's an explosion of interest, I would say. You can see so many social medias promoting AI-based articles, and even recent journals with so many publications, digital therapeutics and technology journals. They have so many, every issue will have so many number of topics or information regarding the AI. Even the American Diabetes Association supports the use of AI in diabetes care. So the other, so many subsets, the machine learning, natural language processing, robotics, fuzzy logic, expert system, knowledge base, these are all terms which all of us will have to be aware in the next days to come. So this slide actually summarizes the entire application of AI in diabetes management. As you could see, the methodology on the left hand side, vector method, and deep learning, machine learning, case-based reasoning, fuzzy logic, so many things. And it can be used in diabetes prediction, dietary guidance, retinopathy assessment, exercise guidance, insulin dose recommendations, blood sugar monitoring, foot ulcer prediction, hypoglycemia detection, peripheral neuropathy, and diabetes management. So where does this information come from? The AI, who gives the input? So the wearable sensory sensors which we have, the devices which we use, the smartwatches, all these things, smartphones, apps where the data is being recorded, EMRs, telemedicine data, and lots of social communities. These all give data. You can see the application of just a smartwatch can give so much amount of information, and which can be accumulated and which can be used for future data generation. So something like these innovative devices are also there, where the armband can be used, the daily energy expenditure. How can somebody calculate the energy expenditure, temperature variations, calories, all these things. So these things are very essential. So something like a case-based reasoning. This is actually I've shown the the chart there. If you could see, a problem arises. It's actually a new case. The system tries to retrieve information, and it revises it, reuses the information, solves the case. So a solution is reached. Now again, a revision happens. A proper case is being registered, and then the information is being retained, and such similar things happen, and it accumulates the data of all the previous cases, and it becomes a subset, which is a case-based reasoning. So every case and the solutions are based on these cases. So artificial neural networks, which I told in the deep learning, they have the power of training and generalization. And they are composed of neuron layers, as what we see in our human brain. So many layers: input layer, hidden layers, output layers, and functions like predicting diabetes, perception, classification, pattern recognition, and training can be done. So the application of AI, this is what I showed you in that previous slide, where the diabetes risk can be predicted, personalized lifestyle recommendation will be given, early detection of diabetes, usage of wearable devices, new drug delivery, telemedicine and remote monitoring, chatbots and virtual health assistants, population health management, research and data analysis, and patient engagement and education, which is actually very, very vital, because in day-to-day practice, we may not be getting 5 to 10 minutes to deliver the education which you want to give. If the information is readily available to the patient, they can always use the information to access the data. And basically, it's an entire ecosystem of digitally enabled diabetes care. It enables easier self-management, greater support, better outcomes, and higher quality of life. See, in a clinical practice, you may be thinking like, okay, it's only a plain clinical tool. But you can see, even from the front desk to the support system, everywhere you can use the AI. Okay, right from the time where the patient enters till the time the patient leaves, AI can be incorporated and used right from documentation, analysis. So many tools can be used. And the longevity industry, this is also coming up in a very big manner, and the use of AI is also increasing in terms of regenerative medicine and cell therapy, gene therapy, etc. AI in diabetes prevention. So personalized tools can be made available, and prevention plans can also be made available, and the progress of these individuals, monitoring these individuals and giving them alerts like, okay, this is what you have to do, try to restrict down on the carb intake, the exercise pattern you have to increase a bit more. These will help you to prevent diabetes for the next few years. These kind of auto-generated information can be made available with the help of these kind of systems. If you could see here a subset of data where the microbiome of the individual, blood tests, questionnaires, anthropometrics, and the food consumption, all these are taken, a personalized nutrition prediction is done, and then it gives a personalized dietary plan. Imagine almost 10, 20, 30, 100 people are giving these data. So a standard dietary plan may not be possible for all the given individuals. So it has to take into consideration that all this data, extracting the information and giving a fine output for each individualized patient. So even in categorization of diabetes, if you take into consideration just plain type 2 diabetes mellitus, a person with 3 years of diabetes may not be responding to the standard OHS, but a person with 30 years of diabetes may be responding to just plain metformin 250 milligram. This is where the cluster classification helps. There are so many clusters in diabetes, and determining the care for these clusters becomes difficult in clinical practice. With the help of AI, you can identify which cluster the patient belongs to and what treatment can be given, and further management regarding the diabetes care as well. Even in the diagnosis, medical images, for example, retinopathy screening, all it is very much helpful. So you could see here the data, this is what I told you, data extraction happens at each levels, and when the lesion is detected, you get the images like this. In the images, what are all the findings? The system analyzes and gives you the output. So the data sharing can happen both to the patient and to the practitioner. And to the patient, it can be made available after final revision by the practitioner. See, the data goes to the system analyzes the data, and it comes through to a message with the patient. And there you have the clinician on the right hand side. There the clinician also gives a personalized feedback, and they can interact on telemedicine. This is something like connected meters, where you have glucometers, but these glucometers can be connected to the mobile apps also, and you can have data accumulated there. Even if the device goes wrong, some problem happens to the device, you have data at in the backup, in these apps. Something called smart shoes. These are also going to be in the market in the coming years, where all the foot metrics, we have now foot lab entirely, where you can be assessing the foot pressures and all those things. Simple use of these devices will help us in analyzing the foot metrics and the pressure changes, temperature variations, foot strike, all these things can be made easily available. And thereby in this graph you can identify that an easy diagnosis of early foot problems can be made available. So you can see a spectrum of usages by using these smart shoes. Diabetic kidney disease, this is something which is very interesting, where you can see the usual CKD, EGFR calculation, we can do in the usual mobile applications, we already do that. But using these AI, you can diagnose so many things like imaging diagnosis, pathological diagnosis, and wearable dialysis devices. Say something like smart kidney, which can come up in the future. The patient need not get admitted in the hospital and do the dialysis entirely. Smart dialysis box is going to come up, where it will be an ambulatory dialysis which can be possible in the coming days. Diabetes management, AI powered apps are available. Insulin dosing, it is very important, because that is what we make mistakes in the clinical practice. Sometimes we may go wrong and adjusting the dosages and all those things. It basically takes into consideration the carbohydrate counting and the insulin sensitivity. Each individual which generates the data, the system analyzes the carbohydrate counting, insulin sensitivity, thereby helpful in predicting the future insulin dosage for any given diet. And closed loop remote monitoring systems, various CGM devices and all that. So twin technology, which is also there into the market already for so many years, where you can actually personalize the dietary plans and predict what can happen in the future, and give you a customized dietary plan, exercise regime, all those things, and helpful in diabetes remission. So the ADA, it recommends that AI offers significant rate of remission for diabetes, type 2 diabetes, compared to the standard care which we provide. Even the diabetes treatment, I told you, gene therapy, cell therapy, newer drug targets can all be available. So many companies are there in diabetes treatment involving AI in a very big manner. And the apps also, I'll just show you a few apps. See, this One Drop app can actually track the diabetes sugar levels and actually give personalized recommendations. It has health coaches in the backup, where they can give the personalized recommendations. Similar thing, sugar.iq. You see something on the right hand side. I'll read it for you. I see that your sugar is often below target between 12 p.m. to 3 p.m. on Saturdays. You might be doing something different at that time. I will keep an eye on the patterns during this time as I get more data. Something had happened earlier in the previous Saturday and it is giving you an alert. Okay, Saturday is coming, 12 p.m. to 3 p.m. Something wrong happened last week. So be a little careful. Meanwhile, I am also analyzing the data. Who will do it for us? No doctor can do that. No health educator can do this. Not even the patient will be aware that previous Saturday something happened or 1 month back some Saturday something happened. Okay. So My Sugar app, it is actually like a gamification app where you have so many metrics available. And Livongo, this is like a subscription-based app only. The Medtronic Guardian Patient Connect, it's an AI-powered continuous glucose monitoring support system, and it provides real-time sugar monitoring to the smartphone apps itself directly. You needn't take the help of the CGM device every time. In the mobile app itself, you can find out the data. Dexcom Clarity, this is also another CGM-based device where you can monitor the sugar levels in the app itself. Tidal Pull Loop is an open source do-it-yourself automated insulin delivery device. It is still under development. Hopefully it will hit the market, abroad market in the next few years. The Tandem Control IQ, this is also an insulin pump that automatically adjusts the insulin delivery based on the blood sugar levels and the other factors. Recently we have something called a basal system automation. You know, in spite of you fixing the basal dose, the basal system will automatically keep coming. But these new devices will actually make sure that even the bolus doses will come automatically. You don't have to feed that this much amount of unit, give me as bolus. Whereas in the insulin pump, it will automatically deliver even the bolus device. So this is what regarding the My Sugar Diabetes app, all these things you can see, so many reward points happening, badges you get, leaderboards, so many things which will be more helpful in children, adolescents, type 1 individuals, early type 1, and even in elderly, because we may not get to give proper motivation at times. So these people can get proper motivation and it might help in good diabetes control. So there is something called smart pens which will also be coming in future. It's already there abroad, where I'll just talk regarding the Novo pen, which uses the NFC technology. You have these smart pens where it will be connected to the app. Okay, every time you use any particular insulin, that will get recorded in the app. You don't have to make a note of it. You don't have to remember that this time I took this much amount of insulin. Particularly helpful for patients who keep changing their insulin doses based on the dietary diet. So this will make sure regarding the insulin dosages, and even recommendations can be made in the future days with the help of these smart pens. Okay, artificial pancreas. This is actually something which is very important, because this is where the entire technology of diabetes technology means basically it is artificial pancreas only. The Medtronic Minimed 780G and the Tandem Control IQs, these are in development, and once they come, it is going to revolutionize the insulin pump diabetes management. There are various challenges in AI. Whatever is said and given regarding the benefits, there are so many challenges. Regarding the transparency of the data, equity of services both to the urban and to the rural people, and the cost involved behind this. How much cost is going to get spent from the pocket of the healthcare system or the patients, and who are going to be the consumers? Are it going to be only the patients, or is it going to be like commonly available to the entire public? The data privacy and the security, fairness and limitation of data, accountability. Who is going to take accountability of all the data which is being generated? Something wrong happens in the system, who is going to hold responsibility? The bias, definitely any system will have some bias in the initial days, and the risk of dependence. This is what is something which is very important, because we may be totally dependent on the AI system in the coming few days. It wouldn't be nice if I don't conclude this presentation without talking something about the chat GPT. You see here the entire CGM data, I mean graph, and on the right hand side the chat GPT analyzes the data and gives you the entire thing. Even though this data can be available on the CGM graph itself, you will get the time in range, all those things, but you can see the standard deviation, the hypoglycemia, hyperglycemia occurrence, median glucose levels, mean glucose levels. Every analysis can be made easily available with the use of chat GPT. Smart patients are not very far away from us. You can expect these kind of patients coming to us in the next few years. And smart doctors as well, where they may be dependent more on the system for getting a second opinion. So our ancestors or earlier generations already told information is wealth. So this AI basically uses the information for giving us the data output. And we should not get more dependent on this AI. Definitely proper training is required. We need to make use of this AI in a proper manner to generate data and take the necessary information only. So definitely you need to try it yourself. No matter what I explain or how many other lectures you attend, you need to sit and start using these chat GPT systems, at least basically, or some AI based system. Definitely you will understand how beneficial it is. Can anybody guess who made this presentation or from where the entire text came? No, but somewhere close to it. It's basically AI based only. I did not type even a single word in this presentation. It was totally taken from Bard AI. Okay, I just typed I need artificial intelligence and diabetes care, and the amount of words in 10,000 words, in 20,000 words, like that. You need to give the proper keywords. You get the entire information. No references needed, nothing is needed. You just get the entire thing. Actually, we can even generate PowerPoints, but it would be not nice to generate readily available PowerPoints for a common public platform presentation. For our own reference, definitely we can use. So that's the power of AI. If used properly, definitely we can get lots of information and generate good amount of data. Thank you.
So this is new area. Dr. Wasim has very well highlighted, and he had gone through also. Even though the machine is or computer is giving information, he has to go through. So human application or human brain application should be there. Of course, to learn that very difficult, because some of our patients, still you also may come across, 30 years before meters were not available. Now meters are available. Again, at the time of introduction of meter, very difficult. They have to take one drop and apply the drop and wipe it and then insert it. These are some procedures. So they found difficult and they didn't do properly. Now after the arrival of all new meters, easy to learn. But unfortunately, many of our patients are not learning. And meters are also, as he told, storing the informations. Fasting blood sugar, postprandial blood sugar, random blood sugar, even cows also some of the meters are giving. And all your CGM, continuous glucose monitoring, also giving a lot of information. And as he told, smart pen is going to come. Smart pen will get connected through Bluetooth, through the CGM. Then according to blood sugar, it will calculate the insulin and give insulin also. So of course, days are going to get changed. To start with, we doctors should get changed first. So unless we get changed, of course, we are getting tuned. Nowadays, I used to say, even the cobbler and the sweeper, everybody is using cell phone now and smartphone now. While they started using those smartphones now, we can learn also, we can in turn translate this message to the patients. And as he pointed out, we can identify the risk group, we can take preventive steps, taluk-wise, district-wise, village-wise, where the problem is more, where the uncontrolled state is more, where the complications are more. All those information we can get in future by feeding everything into the computer. So this artificial intelligence is a growing area. So I'm happy Dr. Wasim had gone through and presented nicely. So thank you. We will move on to Dr. Bablo's topic, diabetic foot, plastic surgeon's perspective. So of course, Dr. Bablo need no introduction for this audience. Of course, he is known general surgeon as well as plastic surgeon, and I have moved with him for more than 3 decades now. And many cases of my diabetic foot is being tackled by him. He saved many foot of my patients. Over to Dr. Bablo.
As chairperson has said, Dr. Pablo sir does not need any introduction, but as a routine, Dr. Pablo Redura, a consultant plastic and cosmetic surgeon, completed his MBBS from Madras Medical College, MS from Stanley Medical College, super specialty from Madras Medical College. He is the best outgoing student in general surgery and gold medalist in MHC. Has 2 decades of experience in a plastic surgery and a lifetime member of Indian Association of Podiatry. An area of interest is cosmetic and plastic surgeries, laser, trauma, and diabetic foot surgeries. Sir, all yours.
Thank you, sir, for your kind words. It's a difficult job to be a middle order batsman. I hope I keep the innings momentum going. Thank you all for sparing your Sunday and coming here and listening to this CME. Why does a plastic surgeon need to speak on a diabetic foot? What has actually changed? When we were actually house surgeons, we found that it was usually the poor male house surgeon and the junior most PG who was allotted to the septic ward. The septic ward was, distinguished by its own smell, which we hope didn't cling on to you towards the end of the evening. And then when we became PGs also, we found that the first year PG was allotted to the septic ward. All that we could do at that time was, we could maybe amputate a toe which was gangrenous, we could drain an abscess, we didn't know how to prevent a recurrent ulcer, we didn't know how to reconstruct the foot. Only after we came into plastic surgery, we realized that there is much more to the foot than just doing an amputation like this and covering with a skin graft. There are reconstructive principles applicable in the foot in diabetic care, which are similar to trauma as well as oncological reconstruction, which can be used in the diabetic foot as well. The scope of this talk will include toe ulcers, metatarsal head ulcers, local flap covers to cover wound, and microvascular reconstruction of the foot. What has changed in diabetic foot care? Previously, all our attention was focused on the plantar foot. We operated on the plantar aspect, we debrided the wound, we either covered it with a skin graft or gave a total contact cast. We allowed a little bit of offloading by asking the patient not to bear weight, and we hope that the ulcer will not recur. But we failed miserably. Whenever we actually operated on the foot without understanding the dynamics of the foot, the ulcers as a rule came back. So we had to change our thinking. We had to borrow principles from orthopedics to know what to do to prevent the recurrence of these ulcers. A toe ulcer, you could have seen a lot of those ulcers in Dr. Monica's presentation as well. They're usually over the proximal phalanx of the toe. They can be very deep or superficial. Any ulcer that presents like this has to be probed first in the outpatient department to find out whether it is bone deep or not. And it can be superficial, it can go and involve the tendons, or it may involve the deeper bones and structures. When you debride such an ulcer, it is important to keep in mind that the tendon sheath is a criminal in this. Most often, the bacterial infection spreads through the tendon sheath and can track down into the midfoot. So if your debridement stops short at the level of the ulcer alone without tackling the tendons, you might land up with an abscess later in the midfoot. So it's very important to assess the ulcer as a whole and not think it is just limited to the skin or just the bone. It can track down through the tendon sheaths into the foot. Sometimes ulcers can also present over the metatarsal area. The metatarsal ulcer is usually due to muscular imbalance between the extrinsic and the intrinsic muscles of the foot. These cause elevated pressures over the plantar surface of the metatarsal head. Initially, they form a callus. The patient has neuropathy, no pain, continues to walk on the ulcer, and then the callosity transforms into an ulcer. Sometimes the patient might have other issues behind the skin. When we take an X-ray, we might see that the patient has got a callus and flexor deformities of the toes on the left foot. But when you take an X-ray, you notice that actually there is a deformity at the level of the bones. You can see fusion of the metatarsal with the cuneiform, causing a deformity in the foot. And if we tackle only the plantar ulcer without tackling the deformity in the bone, the ulcer will come back. So this is the pathology of a diabetic foot usually. There is macroangiopathy always and sensory neuropathy. These cause a change in the shape of the foot, leading to uneven distribution of pressure. And those areas where there is an increase in the pressure head, they form callosities. In our society, it is very difficult to ask a patient to walk with footwear at all times. The patient continues to walk on that ulcer, and the ulcer deepens, and they land up with an infection. These are the investigations that we usually ask for. An X-ray is always mandatory. It is better to take all three views, lateral, oblique, and AP. And sometimes, if the ulcer is in the heel area, it is better to take a weight-bearing X-ray to know the extent of the problem. We do a handheld Doppler for all patients in our OPD to assess the vasculature. We don't operate on any foot without assessing the vascularity. We do a neuropathic assessment by monofilament test and two-point discrimination to find out the level of sensory neuropathy that they have. In cases where there is a Charcot's foot, we always ask for an MRI assessment to know the deformity. We involve our orthopedic colleagues in this, and they might have to do either a medial or a lateral lift to elevate the pressure before we do a reconstruction in this. At times, a CT might be warranted to know the status of the bones and the deformity and to rule out an osteomyelitis. Our standard 3 procedures for foot ulcers are, for grade 2 ulcers, we do a Keller's arthroplasty with or without a gastrosoleus recession. For the ulcers over the toes, if the joints are flexible, we do a flexor tenotomy. For metatarsal head ulcers, we do an osteotomy. Sometimes we are forced to remove the metatarsal head along with a tendonoclis lengthening. The Keller's gap arthroplasty is done for an ulcer of the toes. If you notice the picture on the left side, the ulcer is situated over the base of the great toe. Previously, we were addressing these problems by operating on the foot at the plantar level. Now we have shifted our focus to the dorsum. We make an incision on the dorsum of the foot. We expose the metatarsophalangeal joint. We remove a part of the base of the proximal phalanx, thus creating a gap between the proximal phalanx and the metatarsal bone. So this is called as a gap arthroplasty. We don't use screws. We don't use an interpositional graft. We just leave the gap like that. We achieve hemostasis and we close that wound. We can either debride the plantar ulcer in the same sitting or we can do it the previous day in the outpatient procedure. Patient is advised to offload the foot for at least 6 weeks. And you can see at the end of 6 weeks, nothing much has been done on the plantar side. We always only relieve the pressure on the dorsum. The ulcers heal on their own after 6 weeks of offloading. These pictures are taken at 3 months post-op. You can see that there is a stable scar at the base of the great toe. Is screw fixation always necessary? This is a point of contention between orthopedicians and us. But studies do indicate that not always screw fixation is necessary. At times when you do a Keller's gap arthroplasty, there is a floppy toe, but the toe is stable enough to have a normal gait, and usually we don't put a screw in when there is infection. The other toes are usually not involved greatly except to have ulcers over the tips. Usually when there are toe ulcers, it is because of a flexion deformity of the toes. The toes are flexed, and it is usually due to a contraction in the flexor tendon of the toes. It's a very simple outpatient procedure done under local anesthesia. We infiltrate local anesthesia into the flexor tendon sheath. We use an 18-gauge needle or a small knife or a cataract knife, and you divide the tendon. And if the joints are normal, the toes spring up into the normal position. The flexion deformity is corrected immediately. The patient is given a soft splint, and then their wound is allowed to heal. Usually we use absorbable sutures. Sometimes we don't even suture those wounds. They heal on their own. The most important dictum in this is, after the completion of the procedure, the patient should be advised to wear footwear at all times. Footwear is mandatory both indoors as well as outdoors. It is very difficult to convince patients in our milieu particularly to wear footwear. With a lot of religious and social circumstances, it's very difficult to convince them to wear footwear. Dr. Praveen will talk in detail about how to prevent ulcers from coming back. Metatarsal head ulcers are more common over the first ray and the fifth ray. There are some patients who have both. As I told you, it is due to a combination of both sensory and motor neuropathy. Motor neuropathy causes weakening of the intrinsic muscles, thus shortening them. There is an alteration in the pressure in the foot. Sensory neuropathy prevents the patient from experiencing pain. They continue to walk on that foot and develop these ulcers. For these ulcers, as far as possible, we try to retain the metatarsal head. We do something called as a sliding osteotomy or a dorsiflexion osteotomy, where we cut the metatarsal at the level just below the head. Releasing the pressure on the metatarsal head, the head springs up, and thus the pressure on the foot is relieved. Very rarely do we have a need to remove the metatarsal head. As far as possible, we should try to preserve the metatarsal head, because if you remove the metatarsal head, you might get transfer ulcers elsewhere in the forefoot. Again, this is one patient who has a metatarsal head osteotomy. You can do a sliding wheels osteotomy in this patient. We don't use screw fixation even after this osteotomy. We allow that gap to persist, and the wounds do heal well after 6 weeks. Sometimes when the metatarsal head is arthritic, osteomyelitic, or if the previous sliding osteotomies have failed, we have no other option but to remove the metatarsal head. In this case, preserving the bone will not help in healing the ulcer. If you just cut the bone and leave it on, it will form a residual nidus and the patient will have a chronic osteomyelitis later on. So in these cases, it is better to remove the metatarsal head. You can see a patient here who has got two trophic ulcers, one on the first metatarsal ray and the one on the fifth ray. The patient has undergone a sliding osteotomy of the first metatarsal head and removal of the osteomyelitic head of the fifth ray. And you can see at 6 months, there is a stable wound, patient is able to bear weight and have a normal gait. At times, when the bone is infected, when the bone is fused with the surrounding bones, the wedge of bone that you take out creates a significant gap, and we have no choice but to put a plate or a screw. In such cases, when the wedge taken is significant, we might have to use a low-profile titanium plate and bridge the gap between the metatarsals so that there is no instability in the joint. When there are recurrent forefoot ulcers, when there are multiple ulcers in the forefoot, and the patient has got a tendency to develop ulcers in the forefoot repeatedly, we should always check for the dorsiflexion of the foot. If we find that the tendo-Achilles is tight and it is restricting dorsiflexion of the foot, we should combine all foot procedures along with lengthening of the tendo-Achilles to increase the dorsiflexion of the foot so that the pressure on the forefoot is decreased and the pressure gets evenly distributed through the foot. This tendo-Achilles lengthening also does not need an open procedure. It can be done percutaneously, leaving very small scars on the leg. Again, it is very difficult to convince a patient who has come with a foot ulcer that he needs surgery on the leg. But I think to prevent recurrences, we should try to educate the patient and make them undergo these procedures so that they don't have recurrences. Sometimes we use flaps to cover skin ulcers on the toes. Simple flaps are available based on the vascularity of the foot. A preoperative Doppler done in the outpatient procedure is enough to assess the vascularity of the foot, and you can use local digital flaps like VY flaps to cover the foot defects. VY flaps are useful when the foot has a dorsal oblique wound where there is less tissue on the dorsum and more on the plantar side. You can shift tissue from the plantar side onto the toe to cover these wounds. You can use transposition flaps where tissue is cut, a rectangular piece of tissue is cut on 3 sides and shifted into the wound. And where you have taken the flap from, you have to put a graft. The only dictum here is you should not take your flap from areas where there is weight bearing. You should take your flap from non-weight bearing areas. You can shift these and provide stable cover over bony areas and pressure healing areas. You can use rotation flaps when the skin is lax. In elderly people where there is laxity of plantar skin, you can rotate a skin flap into the defect and cover the wound. In this, there is no donor area defect. Everything is sutured. There is no requirement for a graft, and it is a single simple scar. Muscle flaps are used when there is osteomyelitis, when you need good blood supply to cover the wound, when you want the wound to heal without infection, and you want a vascularized surface for using skin grafts. The muscle flaps can be used to eradicate infection when there is osteomyelitis and to revascularize digiti minimi muscle or abductor hallucis muscle or the extensor brevis muscle. At times, we can bring even the sural artery flap to cover the foot defects. The problem in this is after you use the flap, you need a ring fixator to prevent pressure on the foot. So we have to take the help of our orthopedic colleagues, ask them to give us an Elizarov fixator to prevent pressure on the foot. You can see in the first picture, there is an ulcer in the heel. The muscle that is there in the plantar foot is transposed to cover the defect, and then a graft is laid on top. You can see at 6 months there is stable skin cover. This is another muscle flap which is used on the lateral side. You can use the abductor digiti minimi muscle to cover defects on the lateral aspect of the foot. On the right side of the picture, you see a medial plantar artery flap, where a flap is harvested from the midfoot area based on the medial plantar artery and is used to cover an unstable scar in the heel, where people have already covered the defect with a skin graft, but it has repeated breakdowns because the quality of skin cover is not durable. You can use muscle with a skin graft on top to give a durable cover. At times, you get defects like this where the bone is exposed and the patient might not be fit for a microvascular procedure. In such cases, again, we can use extensor digitorum brevis muscle transposed to the defect and cover it with a skin graft and get a stable skin cover. You can use muscle flaps to cover difficult areas like the heel or the plantar surface of the foot near the instep, where readily available local tissue might not be available. You might have to take tissue from the calf and use a sural artery flap to cover these defects. The dorsum of the foot presents a relatively easier reconstructive option with the advent of vacuum-assisted closure, which Praveen will be talking about in detail. It is very easy to salvage these areas even if bone is exposed or tendons are exposed. Vacuum has revolutionized wound care. Even unsalvageable wounds on the dorsum of the foot with vacuum can be salvaged and grafted. You can see here, that's a difficult wound. You can see the wound after one stage of debridement, still not good. Tendons are deeper. We want to preserve the tendons. We cannot graft immediately. Patient is not a candidate for a local flap or a microvascular reconstruction. Using a vacuum-assisted closure helps in getting a wound which is granulated really well and will now accept a graft. And the advantage is you can still salvage the tendons. At times you have no other option but to use microvascular reconstruction for reconstructing the foot when there are complex defects. When it is only a skin defect, we can get away with a graft. If the wound is only muscle deep, we can still get away with a flap. At times there is osteomyelitic bone. There are vital structures exposed like blood vessels, nerves and tendons, in which case you need a reliable, solid flap which will not break down in future, which will be durable and will allow the patient to bear weight. In which case we are left with no other option but to use microvascular tissue transfer. In microvascular tissue transfer, the workhorse flaps for the lower limb reconstruction are the latissimus dorsi myocutaneous flap or the anterolateral thigh flap. These flaps come with their blood vessels, artery and vein removed from the donor area, and they are anastomosed to artery and vein in the leg, usually the posterior tibial or the anterior tibial vessels. You can see here, this is a heel defect which has been reconstructed with the latissimus dorsi flap. The other one is so every ulcer need not end in amputation. If seen early, surgical procedures and plastic surgery can help in not only saving the form but also the function of the foot. You need not lose your extensor tendons just because they are exposed in the wound. If you take care of your foot will take care of you. Early diagnosis is a must. Early referral to a surgeon is a must. An appropriate antibiotic, as stressed by Dr. Monica, is must because we are facing a lot of cases with antibiotic resistance. And my surgical chief used to say, no bacteria is resistant to the surgeon's knife. So you should debride early and then cover early. Thank you.
Thank you, Dr. Bablo. He has very well highlighted after developing ulcer, so from mild ulcer to severe ulcer, and what sort of problem he faced during surgery. And of course, they could able to save the limb and reconstruct the limb. So my message for general practitioners or clinicians in diabetes, content and container defect. The content is blood. So hyperglycemia is there, your leukocyte function will get deformed. So phagocytosis and killing the bacteria, all those things get defective. RBC function also will get defective. It will not deliver the oxygen because of elevated A1C, and platelet function also getting defective. So content defect, and container defect is atherosclerosis. So atherosclerosis also will impair the circulation. So poor delivery of oxygen and nutrition, and poor function of your RBC and WBC, leading to all these problems. And to start with sensory neuropathy, then motor neuropathy, and autonomic neuropathy also. If all neuropathy is set in, all these problems will start. Otherwise, all these things are not happening like our road accident or acute appendicitis or renal colic. All these things are happening over a period of minimum of 3 years to maximum of 5 years or 10 years of uncontrolled state only. So as a clinician, repeated message is we should try to prevent diabetes, keep diabetes well under control, identify complications very early and correct the complications. Unfortunately, even if they enter into the problem like this, of course, they are correcting with great difficulty. The patient should struggle and suffer, and surgeon also should struggle and suffer along with the patient. Even after kidney transplant, some of our patients are not maintaining the control. The transplanted kidney is failing again. So to that extent, the patients are ignorant nowadays. And of course, hospitals are having technology. Even after 2 infarction, they go for cardiomyopathy. They go for heart transplant. They don't want to keep the diabetes under control. So to that extent, we have technology to overcome the complications. But unfortunately, it has to be prevented. Diabetic is, otherwise, your diabetic foot complication is a visible complication. Your heart attack or stroke or retinopathy, they are all invisible complications. This is visible complication for the patient as well as the attenders. So better to identify the problem early or prevent the neuropathy to start with. Even they may sometimes develop cataract and retinopathy and your sensory and motor neuropathy in the feet. They may wear the shoes or, chappals. After going for some time, the chappal will go away from the feet because of lack of sensory neuropathy as well as motor neuropathy, and they are not in a position to see also because of retinopathy or cataract. They may leave the chappal in between also. This is all commonly happening, leading to all these ulcers. Of course, after developing ulcer also, there are measures to tackle it. Dr. Bablo has very well highlighted. We'll move on to next topic. Next topic is preventing complications of diabetic foot problem and their management. So preventing complication is one component. After correcting the complication also, the message for every one of you, we should insist the patient to maintain the good control. Otherwise, they face recurrent complications. They face recurrent hospitalization. So once they face some complications, at least from that day onwards, they should keep diabetes well under control to avoid further complication. Over to Dr. Praveen to talk on prevention of complications of diabetic foot problem and their management. Over to Dr.
Dr. Praveen Kumar, our consultant plastic and reconstructive surgeon and diabetic foot surgeon at R.A. Belroth Hospital. Sir completed his MBBS and MS from Stanley Medical College, MCH from Madras Medical College, with a 2 decade of experience in this area of interest, such as plastic surgeries, hand reconstructive and diabetic foot surgeries. So, all yours.
Thank you, sir, for your kind information, and thanks one and all for sparing your time on a Sunday evening to come and listen to this lecture. The topic is prevention of complications of diabetic foot syndrome and their management. Dr. Pablo had outlined the treatment and special treatments in commonly encountered diabetic foot problems. The scope of my talk will be restricted to the prevention of developing diabetic foot syndrome, whether it is in primary, secondary, or in tertiary levels. And what are the new modalities of treatment available to the surgeon to tackle the problem of diabetic foot. So the primary prevention of diabetic foot syndrome, why every treating physician or physician dealing with diabetes needs to know. 15% of diabetics are liable to have foot ulcers during their lifetime, and majority of the foot amputations are preceded by a small ulcer. And the quality of life of the patient depends on the successful treatment of the ulcers and preventing recurrence. So what are the measures needed at the primary level? These are common to all the persons who are treating diabetic patients. They should advocate adequate medical management for the patient to keep the HbA1c under control. Lifestyle modifications are the need of the hour. With as sir pointed out, for increasing screen time is taking away our exercise time. So lifestyle modifications are a method of primary prevention of this problem. Foot care practices to all patients who have been diagnosed with diabetes should be advised by the primary care physician. And the cessation of smoking plays a very important role to prevent the complications due to vascularity. So why do the diabetic patients have diabetic foot ulcers? The problem is threefold. The main problem lies in the neuropathy developing as a complication of long-standing diabetes or uncontrolled diabetes. The neuropathy affects the sensation of the foot. Due to the loss of protective sensation, people are liable to develop ulcers of the foot. The motor neuropathy results in intrinsic muscle paralysis of the foot, which results in atrophy and formation of faulty joints and producing bony prominences, which predispose to formation of the ulcers. And the autonomic neuropathy causes an imbalance in circulation and decreased moisturization, resulting in dry skin, cracks, and development of ulcers. The second problem in the diabetic patient is limited joint mobility due to the alteration in properties of elastin and collagen, which causes joint stiffness. Compared to the normal population without diabetes, diabetics are found to have this problem more commonly because of this problems in elastin and collagen. They have limited joint mobility. Because of this limited joint mobility, they have high peak plantar pressures over specific bony prominences, which results in the common ulcers which we have seen, like the metatarsal head ulcers or the interphalangeal joint ulcers or the heel ulcers. The third problem which leads to the formation of diabetic foot ulcer is the vascular problem, be it microvascular or macrovascular, which can be commonly diagnosed by the primary physician when he checks for a pedal pulse. An absent pedal pulse should immediately warn the physician to refer him for further assessment of vascularity, because the decrease in vascularity is the single major problem which immediately leads to major complications resulting in amputation of the foot. So the classification of diabetic foot ulcers according to Wagner, which is commonly followed, is grade 0, where there is no ulcers of the foot, but there are signs of pre-ulceration, like a thickened epidermic layer, which we call as callus. Callus is the first sign to warn you that an ulcer is going to form. And grade 1 is a superficial ulcer, where there is a small breach in the epidermis and dermis of the skin, but there is no exposure of the underlying tissues. Grade 2 ulcer, the depth of the ulcer can involve the subcutaneous tissue, bones, or tendons, but without any infection. If there is any infection or abscess, or there is infection extending to the bone, then it becomes a grade 3 ulcer. The grade 4, where the complications are due to the vascularity superimposed on that infection, producing a localized gangrene of the toes alone. And grade 5, when there is extensive gangrene of the whole foot, where there is no other option other than a major amputation. I want to highlight the role of a pedobarogram. What is it? This is an novel device where we can measure the plantar pressures during normal posture or during gait. What does this convey to us? The treating physician, depending on the pedobarogram, can assess where there are peak plantar pressures. Those areas of peak plantar pressures are the areas where you get ulcers, or the ulcers. When you see a patient with an ulcer and we do a pedobarogram, we find out the specific points where there are peak plantar pressures. The aim of the surgeon with this is to offload the foot where there is peak plantar pressure. Normally, the plantar pressure should be uniformly distributed over the heel, the forefoot, and the first toe. So, any deviations from this normal posture of the foot can lead to peak plantar pressure in one specific area, leading to a formation of an ulcer, and which will not be treated completely only with debridement. You have to address the underlying mechanism to offload the ulcer. So this is the point which I wanted to convey. The finding out of peak plantar pressures in foot by a pedobarogram will assess the surgeon to prevent ulcer recurrence. So the primary prevention is the advocacy of the patient of proper health foot care practices. The secondary prevention of diabetic foot ulcer is on the surgeon, preferably once there are visible signs of diabetic foot syndrome. Like it might start with a callus, might progress on to an ulcer with osteomyelitis, or an non-salvageable toe with infection with gangrene. So it might start with a callus or an end with a gangrene. So the secondary prevention of diabetic foot ulcer is done by the surgeon who is treating the patient with a diabetic foot ulcer with the following methods. So for this step only, I just advocated the importance of using a pedobarogram to find out the areas of peak plantar pressure. So if you see the patient with an callus and you do a pedobarogram, you can find out the area where there is peak plantar pressure, and we have to find out the biomechanics which are producing the peak plantar pressure. Only if you address the underlying biomechanics or the alteration in the biomechanics which are producing this problem, you can prevent recurrence of these ulcers. Or else, once you treat the ulcers, they are liable to come back again, even with the use of footwear, without addressing the altered biomechanics of the foot which we have diagnosed with the pedobarogram. There is no chance to prevent the recurrence. So I'll be speaking, giving a hint about the secondary prevention. Once you have started seeing patients with callus and ulcers, the treatment is pressure offloading, total contact casting, and use of customized footwear after treating the initial offending agent. After the surgeon's debridement takes care of any infection if present. I have highlighted the surgical procedures, or which are called internal offloading. See, the pressure offloading can be done with footwear. In our set of patients, we can't be advocating them to wear footwears throughout the day. or throughout the day, 24 hours, they can't be expected to wear footwears. So, as a surgeon's perspective, understanding the biomechanics of the foot and attempting surgical procedures which will offload the pressure is the key of introducing the surgical procedures for treating of recurrent diabetic foot ulcers. This we call it as internal offloading. The external offloading which we give by the footwear may not be successful due to the reason which I have highlighted. The patient may not be wearing the footwear throughout the day. And in our patients we see they use footwear only when they go outside the house. And inside the house they walk barefoot. And most of the time they might be spending indoors. So the very use of advising the footwear gets spoiled due to this practice. So because of that only, we have progressed with the knowledge of the understanding of biomechanics of foot and advocating surgical procedures which are called internal offloading, following which the ulcer recurrence can be prevented. These are the examples of the footwear which we commonly use for loading, that is offloading the ulcers. For any 4-foot ulcers over the head of the metatarsals, after treating the ulcer and cleaning of that infection, we advocate this anterior ortho wedge, where the ulcer or the weight of the foot over the 4-foot areas is offloaded by a gap. So this is called an anterior ortho wedge, which is used for the post-surgical treatment of 4-foot ulcers, that is head of the metatarsal ulcers and all. And there is a posterior ortho wedge footwear where you have advised this footwear for management of heel ulcers. And this is the method of total contact casting for treatment of ulcers after debridement. After debridement of the ulcer and clearing of that infection, to prevent recurrent weight bearing on that ulcer, the part of the foot which bears the ulcer is prevented from bearing weight. That is the idea of the total contact cast, or the weight bearing is distributed evenly towards all the areas of the plantar surface of the foot, so that one particular area is prevented from bearing all the weight. That is the idea of putting a total contact cast, which is advocated for 6 weeks after clearing the infection. It is the gold standard method of healing of ulcers following debridement. So I told you this the methods of surgical offloading. Pablo had spoken about the tendoachilles lengthening. Tendoachilles lengthening will prevent excessive offloading on the 4-foot region, thereby preventing recurrence of 4-foot ulcers. The flexor tenotomy prevents weight bearing on the tip of the toes, thereby preventing toe ulcers, toe tip ulcers. As I told you, there is limited joint mobility due to problems with elastin and collagen. So these patients will require selective plantar fasciectomy depending on where the movement is limited. Most commonly in the great toe, where the selective plantar fasciectomy might relieve pressures over the first metatarsal head, preventing the recurrence of IP joint ulcers. And Keller's gap arthroplasty, it is a surgical procedure where we do this procedure to prevent recurrence of the IP joint ulcers over the great toe. Metatarsal head excision is the procedure for preventing recurrence over the metatarsophalangeal joint ulcers, commonly seen in the first ray and the fifth ray. After treating the ulcers over the first and fifth ray, we might expect transfer ulcers over the second, third and the fourth rays, which we have to explain to the patient and advise proper footwear to prevent the recurrence or the occurrence of transfer ulcers. And Wales eye osteotomy is an alternative to the metatarsal head excision when the head is not deformed, but there is an acute hyperflexion of the metatarsophalangeal joint where the head is, we do an oblique osteotomy of the head so that the distal part of the osteotomized portion, that is the head of the metatarsal, slides dorsally. This prevents pressure over the the metatarsal head and helps in healing of the ulcer and preventing recurrence of the ulcer. Coming to the tertiary prevention, once there is non-salvageable infection, we have no other go to amputate. It is the surgeon's nightmare. Patient comes to you when we have no other option other than to amputate. But the recent advances in plastic surgery have given hope to the patient where we can reduce the level of amputation to provide a weight-bearing foot or else a weight-bearing stump. So these are the advances of plastic surgery which we have achieved. And now I'm going to speak about the newer modalities of wound healing which will help the surgeon who is treating the infection after treating the infection or during the process of treatment of the infection, how the newer modalities have helped in wound healing, achieving wound closure. So negative pressure wound therapy, which is commonly called as WAC therapy, has revolutionized the treatment of complex wounds. It has made the treatment of complex wounds a bit easier to the surgeon. So what is the principle behind it? It is by applying subatmospheric pressure to a wound intermittently or constantly to achieve optimal healing conditions. The technique involves covering the wound with a medical grade sponge in an airtight manner and connecting the same to vacuum source. The source of the vacuum is through a pump. The ideal pressure to maintain is a negative pressure of 50 to 125 millimeters of mercury, which is proved to be the ideal negative pressure which will help in wound healing. How this WAC therapy helps in wound healing? See, the WAC therapy helps in mechanical shrinkage of the wound due to the negative pressure and in maintaining a moist environment of the wound. Any wound will heal better when it is in a moist environment. It removes exudates from the wound and reduces edema of the wound edges. It reduces the bacterial load of the wound by means of constant suction. And the application of constant negative pressure to the wound creates ideal conditions for granulation tissue formation, which is due to the formation of extracellular matrix, and neovascularization, as we can see in the wound, where the wound becomes very well vascularized and can be covered by easier surgical options rather than going for complex flap surgeries. So indications are any chronic or acute debrided wounds, and in complex wounds where immediate surgery is deferred either due to the health condition of the patient where he might not be fit for major reconstructive procedures or financial constraints to undergo a procedure immediately after the first one. The contraindications to WAC is not to apply the therapy over a vascular anastomotic site directly or an inflamed bowel. Vascular anastomotic site might get a blowout and an inflamed bowel might create an intracutaneous fistula. And the chronic ulcers where you suspect malignancy and malignant ulcers are absolute contraindications for WAC therapy. So this picture shows a debrided wound which is to be closed, but there is a cavity. The rest of the wound is covered with a well-formed granulation. How to close a cavity? So for this we use this WAC therapy, negative pressure wound therapy, which obliterates the cavity and provides a stable bed for a simpler procedure like skin graft. Even in the debrided wound exposing extensor tendons, the WAC therapy promotes granulation formation over the exposed extensor tendons which are not frankly infected. Any infected tendons we cannot salvage. Tendons or critical structures which are devoid of vascular cover, like tendons devoid of paratenon, bones devoid of periosteum, can be salvaged by VAC therapy. When they are not clinically infected, VAC therapy promotes granulation tissue formation over these critical structures, thereby increasing the chance of the salvage. The wound can be covered with a skin graft which can cover the entire wound. See, on the extreme left, you see a debrided wound which is exposing bone, and the size of the wound also is large. And the quality of the debrided wound is suboptimal for immediate skin graft reconstruction. The center picture shows the nature of the wound after a series of VAC dressings where the cavity has been obliterated and a wound bed which is suitable to accept a skin graft has been created by the VAC therapy, and the wound has been successfully covered with a skin graft. So this VAC therapy has revolutionized the management of complex wounds and has come to the plastic surgeons or the surgeons' help in a great way. Any complex wound which is not exposing critical structures with infection can be successfully covered, or it can offer an option to be covered with simpler procedures after completion of VAC. So the next modality which I am going to talk is about the hyperbaric oxygen therapy. The principle of delivering this hyperbaric oxygen involves giving oxygen to the patient in a pressurized environment. The normal atmospheric pressure of 1 atmosphere, but here we create a pressurized environment up to 2 or 3 times of normal atmospheric pressure, and delivering 100% oxygen. Oxygen what we breathe is only 21%. We deliver 100% oxygen in a pressurized atmosphere. What does this produce? It increases the oxygen intake by the lungs. The normal oxygen concentration in plasma is only 3 ml per liter. How the oxygen is delivered to the tissues? It is by the formation of oxyhemoglobin, and from the oxyhemoglobin, the oxygen is delivered to the tissues by the dissociation. But what hyperbaric oxygen therapy does is it removes the role of hemoglobin dependent oxygen delivery to the tissues. It increases the plasma concentration of the dissolved oxygen. See, from a concentration of 3 ml per liter to approximately 60 ml per liter, it can be achieved by hyperbaric oxygen therapy. And when the plasma has 60 ml per liter at the tissue level, it can be delivered easily to the tissue without the help of hemoglobin. So this transient hyperoxia, which produces 60 ml per liter of oxygen in plasma, is the basal metabolic oxygen demand for cellular metabolism in most tissues. So when patient is having anemia, when the hemoglobin level is low, this level of this treatment modality can improve oxygen delivery to the tissues independent of the hemoglobin carrying capacity of the blood. So how does this hyperbaric oxygen improve wound healing properties in the wound? What are the cellular effects caused by hyperbaric oxygen? It promotes collagen matrix synthesis and angiogenesis, which are the cornerstone of forming granulation tissue and neovascularization. It kills anaerobes and prevents growth of certain bacterial species like Pseudomonas, which are mainly encountered in necrotizing fasciitis, which is a complicated, life-threatening infection seen commonly in diabetics. It prevents the production of the clostridial alpha toxin, which is seen in gas gangrene or anaerobic myonecrosis by specific organism like Clostridium difficile. This alpha toxin produced by the Clostridia is prevented by giving hyperbaric oxygen. So it has got an indication in treatment of gas gangrene. And the hyperbaric oxygen, transient hyperoxia of the blood of plasma, it restores the neutrophil mediated bactericidal effect previously present in the hypoxic tissues. So this is the commonest modality by which hyperbaric oxygen helps in necrotizing fasciitis or in acute infected wounds also. In addition to the surgeon's debridement, this hyperbaric oxygen can come in help to salvage of complex wounds. It reduces the leukocyte adhesion and prevents release of free radicals in pre-reperfusion injury. So that's why hyperbaric oxygen has been advised as a method of treatment for crush injuries, preventing reperfusion injuries. So we see the indication of using hyperbaric oxygen in diabetes, in necrotizing fasciitis, myonecrosis, that's gas gangrene, ischemic non-healing ulcer. Due to poor vascularity, we see the reasons which I had highlighted before. In the ischemic tissues, the oxygen delivery is not sufficient for the resting cellular metabolism. So the increase in the plasma concentration at that level will help in healing of ischemic non-healing ulcers. And it can also be useful in the treatment of osteomyelitis, where without hyperbaric oxygen therapy, we might end up in just doing a sequestrectomy and removal of the bone. And refractory non-healing ulcers, in spite of your surgical procedures, when the wound is not healing, hyperbaric oxygen therapy offers a great hope. So the treatment schedule of the hyperbaric oxygen therapy, it lasts typically around 1.5 to 2 hours. The first stage is stage of compression, where a pressurized environment is created. It might be by using 100% oxygen or by using a nitrogen helium air mixture, where the pressure of 2 to 3 atmospheres is created inside the chamber and the patient has to be inside the chamber. And the therapeutic stage, where you given 100% oxygen to breathe directly, be it in a single place oxygen chamber or through masks when it is done in a multi-place chamber. So hyperbaric oxygen therapy can be given through single monoplace chambers or multi-place chambers. This stage of therapeutic stage of HBOT lasts up to 90 minutes, 1.5 hours to 2 hours. And the stage of decompression, where the pressurized environment is slowly released for a period of 10 minutes. So the sessions can be planned thrice weekly. We'll have 30 to 40 sessions needed to assess the clinical improvement. This is a costly method of treatment, but it offers great hope in the treatment of necrotizing fasciitis and gas gangrene. The HBOT treatment schedule greatly reduces the number of surgical procedures required for debridement and yearly clearing of infection also. The issues of concern of using HBOT therapy is due to the lung damage, where the transient tissue hyperoxia is present, and the results of creation of a compressed atmospheric pressure, like 2 to 3 times more. You have to create a compressed environment, which results in barotrauma, like it might result in rupture of the tympanic membrane or barotrauma to the sinuses. And the problems of transient hyperoxia can be seen in eyes, where you can have a reversible transient myopia, cataract or retinopathy of prematurity. But these issues of concern are usually reversible after cessation of the treatment with hyperbaric oxygen. Rarely in monoplace chambers, where we use 100% oxygen as the pressurizing agent, there is a chance for fire accident. So this is the treatment chamber. The picture on the right shows a monoplace chamber, where only one patient can be treated at a time. It will be covered with a glass glass envelope only to prevent a patient getting claustrophobic. You can speak with the hyperbaric oxygen therapy, the supervisor in charge. You can converse with the help of microphones. And the picture on the left shows a multi-place chamber where many patients can be treated at a time. The difference between the two is in a monoplace chamber, we use 100% oxygen as the agent for the compression as well as for breathing 100% oxygen. But in a multiplace chamber, the oxygen is delivered by masks or by hoods, and the pressure is created by nitrogen helium air mixture. The multiplace chamber offers somewhat better option when compared to monoplace chamber, but it all depends on the cost constraints where this facility is being inaugurated. So this is a case of necrotizing fasciitis, which requires surgical debridement. After the initial surgical debridement, treatment with the hyperbaric oxygen has reduced the need for further debridements and established early control of infection and spread of this necrotizing fasciitis proximally. This is a case of gas gangrene, which requires immediate surgical debridement and removal of the involved muscles with myonecrosis, following which the treatment with hyperbaric oxygen has resulted in rapid clearance of infection, which will take a long time if only surgical debridement alone is contemplated. Next treatment modality is platelet-rich plasma therapy, which involves separation of platelets from other components and concentrating them in plasma and injecting this platelet-rich plasma into specified target tissues. What it achieves? It improves the promotion of growth factors like platelet-derived growth factor, vascular endothelial growth factor, fibroblast growth factor, epithelial growth factor. What these growth factors are important for? These growth factors are required for the formation of extracellular matrix and new blood vessels, what we term as granulation tissue. Granulation tissue is nothing but vascularized extracellular matrix, which are triggered by the growth factors present in abundance in the platelets. So this PRP therapy offers a new treatment modality of chronic refractory non-healing ulcers in diabetic patients, even after doing surgeries, skin grafts, where there is repeated breakdown and ulceration formations in non-weight bearing areas also. You might be left with option wondering what is the problem. This platelet-rich plasma therapy might come in for your rescue. So the procedure involves collection of whole blood and centrifuging and separation the blood from the RBCs from the plasma. And the RBCs get separated in the bottom, plasma in the top, and between these two we get a buffy coat which consists of leukocytes and plasma, leukocytes and platelets. So this layer, after the first spin, we take only the part of plasma and the buffy coat, and that is subjected to a second spin. And this second spin concentrates the platelets alone. So we take platelets along with some amount of plasma to create a liquid platelet mixture, which is called the platelet-rich plasma. We use this platelet-rich plasma for treatment of this chronic refractory non-healing ulcers. Platelet-rich plasma has got many uses. I am speaking about the uses of these new modalities in treatment of diabetic patients. This is an example of a chronic refractory ulcer which has recurred even after doing a skin graft in the non-weight bearing portion of the dorsum of the foot, first ray. So where the platelet-rich plasma has been injected locally into the edges of the wound, which has helped in contraction of the wound and healing without any surgical intervention. The last newer modality in treatment of wound healing is the use of acellular dermal matrix. The acellular dermal matrix is what is a soft connective tissue graft. So we harvest skin from cadavers. This can be a this allograft from humans, like it is a skin from cadavers, or it can be xenograft from porcine or bovine source. We then decellularize that component. That is, no cells will be there. Only the extracellular component will be retained as a gel, as a sheet. The process of removal of cells is to prevent the immunogenicity and rejection of this extracellular, this dermal matrix. Only when the cells are present, the chances of rejection, immunogenic rejection is there. So the idea of removing the cells negates the effect of immunogenic rejection. Only the intact extracellular matrix is preserved, and this extracellular matrix comes as a sheet which can be used in the treatment of wounds to achieve optimization of wound healing. The intact extracellular matrix acts as a scaffold into which the donor site cells can regrow, form new blood vessels, and incorporate it. So the extracellular matrix, when applied to tissues without vascular kind of cover, like a tendon devoid of paratenon or a bone devoid of periosteum, can form granulation over the bare tendon or bone, thereby facilitating closure by skin graft alone. Otherwise, without the use of this, the only option of covering non-vascular tissue is by a flap. The cost constraints and the patient's fitness to undergo a major revascularization or a major microvascular procedure, this acellular dermal matrix will come in handy. See, this is a complex wound following debridement, where most of the wound is covered by healthy granulation, but only the portion over the calcaneum, plantar aspect of the calcaneum, is bare. A skin graft cannot be put over it. The patient is not fit for a major revascularization surgery because of his health conditions. All the procedures have been done under nerve block. So no regional or general anesthesia. For this patient, we have to achieve wound closure with a skin graft. That is the option which we are left with. But how to cover the complex areas where a skin graft will not take, like an area of bare bone, or the picture on the right where a portion of tendoachilles bare tendon is exposed. So this acellular dermal matrix comes into our rescue. We cover the areas under question with this dermal matrix. See, the area which is covered by dermal matrix, after moisturizing with distilled water, it becomes translucent. Initially it is opaque. So the whole area can be covered with a skin graft. It can be covered with an interim skin graft, which acts as a biological cover, and after incorporation to the tissues, a stored graft can be achieved, that is, can be placed over that particular area if skin graft has not taken in the primary instance. So this, for these patients, without the help of major flap procedures or microvascular surgery, this acellular dermal matrix has helped in optimal wound healing. So the take-home messages of my talk are the successful treatment of ulcers and prevention of recurrence greatly improves quality of life in diabetic patients. So the involvement of diabetic foot surgeon from the initial stages in a patient who has been found to have a foot at risk. The treatment of established ulcers and wounds demands understanding of altered biomechanics in foot and their correction. Without understanding the biomechanics and correcting the underlying problems, you are liable to have recurrences again and again in spite of wearing footwear. And many newer modalities of wound treatment are evolving in the management of complex wounds that would have led to amputation in the past. So these are my take-home messages for this talk.
Right.
References which I have taken. Thank you all for your patience here.
Right. Thank you, Dr. Praveen. You
Thank
have
you, sir.
elaborately covered the newer modalities. Especially, we all know about hyperbaric oxygen and vacuum therapy, and regarding where platelet-rich plasma therapy and acellular dermal matrix therapy are new. Of course, we are in a position to salvage the limb, whatever complication they come across. So, diabetic foot surgeons are helping the patients. Thank you, Dr. Praveen, again. We will move on to the last topic, diabetic drug dilemma by Dr. Senthil Kumar. So, over to Dr. Senthil Kumar.
Dr. V.S. Senthil Kumar, Senior Consultant General Medicine of Bedworth Hospitals. Sir completed his MBBS from PGS Institute of Medical Science and MD General Medicine from Government Medical College Salem. Sir has experience of 2 decades in his field. Sir's area of interest are chronic disease management, hypertension, thyroid dysfunction, and diabetes mellitus. So all yours.
Thanks for the introduction, Hassan.
Thank you, sir.
So, good evening, all. First, I would like to thank you for your attendance in the Sunday evening. And I also would like to thank our MD for organizing this event. And this will be a short presentation. I'll be presenting only 4 to 5 slides. Please bear with me. So, the topic will be like more practical. See, we are practicing and most of GPs will be here. Most of the drugs we use here, I think so you should be aware of the interactions between the drugs. Often we see a diabetic patient with other comorbid conditions. A diabetic patient, around 40 to 50% will have other comorbid conditions like CAD, seizure disorders, and often they'll be taking treatment for diabetic foot infections and some antibiotics. Here in this presentation, I would like to highlight what I felt was most important 4 interactions that would help ourselves and as well as the patients. By knowing the interactions, probably we can avoid the medicines or we can make some dose modifications. First, can we go to the first slide, please? So the first interaction is between the glimepiride and nicorandil. Both of the drugs are well known to all. So nicorandil is an anti-angial drug. As you know, the cardiologists use it very often in a vasospastic angina. So the mode of action of nicorandil is by opening the ATP-sensitive potassium channels in the muscles and causes vasodilation in the coronary vasculature. Now, ATP-sensitive potassium channels are present in the muscles as well as in the beta cells of the pancreas. So the mode of action of nicorandil here is the opening of the potassium channels. Over to the next slide, please. So these ATP-sensitive potassium channels also possess 2 types of receptors, sulfonylurea receptors. SUR1 is present in the beta cells, and SUR2A is in cardiac muscle, and SUR2B is in smooth muscle. So nicorandil selectively acts in the sulfonyl receptor 2A and 2B. Now, very often we use the glimepiride and glyburate. Glyburate is the new name for the glibenclamide, which we use there. They block both sulfonylurea receptors 1 and 2, thereby reducing the nicorandil effects. So the sulfonylurea action is like they close the receptors, whereas the nicorandil effect is they open the receptors. So thereby the nicorandil action is somewhat degraded. I mean, it comes down. Nicorandil action is not 10%; it comes down by 50 to 70%. So now what we have got option is like we can use the glycoside. Glycoside blocks only the sulfonyl receptor 1, which is present only in the beta cells. So thereby the coronary muscles and as well as the other receptors SUR2A and 2B is spared. So thereby we can give full efficacy of nicorandil by using glycoside. So go to the next slide, please. So other thing is the linezolid. This antibiotic is very common among the plastic surgeons, and Dr. Pablo must be very well aware of this antibiotic. Because this antibiotic is favorite because even in renal function we can use it to the full dosage, and it is a bacteriostatic antibiotic. It belongs to an oxazolidine antibiotic, a group of drugs, and we use this drug right and left, but we should be aware of the minor factors. See, it has got some MOI activity, monoamino oxidase. It's an enzyme. The linezolid has got a property to block it. So what does MAO do? Monoamino oxidase is an enzyme which degrades the epinephrine, serotonin, and dopamine, the neurotransmitters, basically neurotransmitters. So by blocking the neurotransmitters, what you do is you sometimes in a patient in the ICU it may cause delirium in patient with linezolid. And MOI can promote insulin secretion as well as insulin sensitivity, thereby causing hypoglycemia. Often we see a patient, in a patient with a kidney problem, we use this linezolid, and the mean time which we often observe is 3 to 5 days for the hypoglycemia to occur. And the recovery phase after stopping the antibiotics takes around 24 to 36 hours. So we should be well aware of this antibiotic and its side effects, because often we will be searching for a cause for hypoglycemia in a patient with CKD, who was previously doing well with a normal dose of insulin, and suddenly they go for hypoglycemia. It's a very common condition which we come across. We had last month we had a case of undiagnosed hypoglycemia, patient recurrently going for hypoglycemia in spite of stopping insulin. Then we found out the cause to be linezolid. The moment we stopped linezolid, the patient recovered after 36 hours. So this should be borne in mind when we use this antibiotic. This antibiotic, we use it very often, and this is the minor factor should be taken. It doesn't mean that all the patients go in for side effects, around say 20 to 30%, but definitely patients with renal impairment, often we see this side effect. Over to the next slide, please. So another thing, this is in ICU setup, we often use voriconazole and azole drugs, and patients with diabetic patients with fungal infections, we use these drugs. You know, sulfonil is an insulin secreted GOG, and it is metabolized by cytochrome P450 enzymes, CYP2C9 isoenzyme. So what does this azole do? They inhibit this enzyme, thereby the metabolization of the sulfonylureas is inhibited. So the action of the sulfonylureas is prolonged. So you get sustained action of the drugs, thereby causing hypoglycemia. So this should be borne in mind when you send a patient with either with a fluconazole or a voriconazole. You try to reduce, if the patient is on insulin, you just reduce the dosage of the insulin so that the patient doesn't go in for hypoglycemia. This should be borne in mind. These are minor factors which may help us in our practice. And the fourth one is, next slide please. Next slide, often we see a patients with seizure disorder and diabetes coexisting, and the patients with complex partial seizures will be using carbamazepine, or sometimes it may be used for neuropathic pain or trigeminal neuralgia. So you find it has got the opposite effect of the other drugs, azoles. Here it induces the cytochrome enzymes, thereby the sulfonylureas and everything is, the drug is metabolized much faster. So thereby the efficacy of the drug comes down, and there is hyperglycemia. So the take-home message is, when you are prescribing a diabetic drug along with other comorbid conditions, be to our understanding, whichever drugs which you can modify, please modify, because the patient may be consulting a cardiologist for the cardiac problem, and they may be coming diabetic to us. So we need to educate the patient, and we need to make some dose modifications. I think the 4 take-home messages will be reached to you. Thank you.
Thank you for bringing these practical points. Even tuberculosis and diabetes are also quite common. So some of the anti-TB drugs, for example, INH, neuropathy will get worsened further in presence of neuropathy. And there are another drug, as he told, after developing CKD, they go for persistent hypoglycemia also. Even after stopping all the drugs, so patient is on Dianyl 1-BD, metformin 1-BD for 5 to 10 years. Then after entering into nephropathy, we may have to reduce the dose. Even after stopping the dose also, some of the patients are entering into severe hypoglycemia or persistent hypoglycemia, because the endogenous insulin, which was insufficient earlier, will become more sufficient. So endogenous insulin is also getting cleared through kidney. This insufficient endogenous insulin earlier become more sufficient, pushing the patient towards persistent hypoglycemia. So these are all some practical points you should learn, as he pointed out. So these are all the area. But of course, in general, there is no much of interaction. But of course, we have to keep all these things in our mind. So I will conclude with a few of my photo gallery. Open meeting, la? Patient is close பண்ணுங்க. ஓபன் பண்ணுங்க. இப்போ டெஸ்க்டாப் போங்க. பேஷண்ட் எஜுகேஷன். ஃபுட் போங்க. எஃப் போங்க. சரி நான் சொல்லிட்டேன். எஃப் போங்க. ஃபுட். ஃபினிஷ் ஸ்டேஷன் என்ன பண்ணுங்க? ஓபன். இது இருக்கா பவர் பாயிண்ட் சேஞ்சர் இருக்கா இல்லை இல்லை So within another 5 minutes, I will show some other photographs.
Thanks and join us பண்ணிக்கலாம் ஜாயின் பண்ணிட்டாங்க
Right. So this he has shown EMED. This is electronic platform. If you make the patient to walk on the platform, so I am standing now, the entire body weight is getting transmitted through sole. If the sensation in the sole is intact, so I can adjust the my foot. If I am standing for a long time, then the callosity will not happen. But if I have neuropathy, so I may not adjust, I may not feel the pressure effect of the foot. So if the pressure effect is felt, the number should be in the weight bearing area, great toe, forefoot and heel of the weight bearing areas. Sorry. In the weight bearing areas like great toe and forefoot, it should be less than 30. Instead of 30, here it is 42 and the forefoot also 34. Once you control diabetes and improve the nerve function, 2007, next. In 2008, the in the great toe, 42 becoming 21 and 34 becoming 22. Otherwise, early identification of neuropathy in the sole can be easy now. This equipment was not available 10 or 15 years before. Now this equipment is available. By controlling diabetes effectively, you can revert the early neuropathy in the sole. Next. Sorry. So similar picture, 104 becoming 68. And this is intertrigo. We have to see the, not the dorsum of the foot alone. Sometimes some of our patients are not even removing the shoes. Better to remove the shoes, remove the socks, and see the intertrigo also. Intertrigo is quite common in diabetic, especially in the winter season. This is walking on the rough surface or in the hard surface, inviting blisters in the feet. So these are all blisters. And these are all again blisters due to chappal, new chappal, and again blister due to chappals. So getting healed. This is again two-wheeler, pillion rider. So the silencer burned. Again, this is in the ICU. This patient is in the ICU in the bare cot without any support. In the ICU, the heels were kept persistently for 2 or 3 days. So they developed blister and also so not only the foot problems are happening in the terrace or in the open space, it is happening in the ICU also. This is rat bite, cockroach bite. This patient had a callus in 2002 because of uncontrolled state. By persistent good control, the callus is getting reverted. So the message is again, persistent good control reverts neuropathy and formed callus. So after correcting all those things, you have to aim for persistent good control. They should not develop complication. Even after developing complications, it is better to persistently control diabetes, by which you can give good vasculature also. Here vasculature is poor, vasculature is better now. Again, this patient had, so again, trophic ulcer not getting healed for 6 months. After good control and maintaining the good control, totally getting healed. Again, this ulcer also not getting healed. After good control and maintaining good control and surgical intervention, getting healed. This ulcer, 4 years not getting healed. After good control and maintaining good control, getting healed. This ulcer also not getting healed for 3 years. Underwent toe amputation, underwent CABG, kidney transplant, toe amputation, all complications he faced. And they are planning for removing the limb also because it is getting infected, the calcaneum is getting infected. Again, by surgical management plus good control, maintaining the good control, making the wound to get healed. See? So totally getting healed. So, right, sorry. So this ulcer, so like that, this patient also had dorsal ulcer. Dorsal ulcer is quite rare because of chapel. Your great toe ring is there, the new chapel got bitten and the blister developed. The blister is not getting healed for 2 years. It is becoming deepened and the forefoot also darkened. Then good control and maintaining the good control, making the ulcer to get healed. So totally getting healed, the color also getting changed. Again, this is top of the toe is getting ulcerated. So the other is called a tip-top toe syndrome. Tip of the toe as well as top of the toe will get ulcerated. Once the tip of the toe and top of the toe is getting ulcerated, it indicates patient facing motor neuropathy as well as sensory neuropathy. Because of motor neuropathy, the intrinsic muscles are becoming weak. Because of sensory neuropathy, they are not feeling the sensation in the top. If they wear the shoes will give friction and cause ulcer, and tip of the toe to bear the weight or to hold the body balance, so they go for ulcer. Tip of the toe also will get ulcerated. Tip-top toe syndrome, it indicates involvement of motor as well as sensory neuropathy. So these are all the other ulcers. The tip of the toe is getting ulcerated, and this is not getting healed for 3 years. This toe got amputated earlier. Again, good control will getting healed. Why it is not functioning fastly? Sorry. This is totally dry. See, sensory, motor, and autonomic neuropathy. All three components. This is side of the toe also getting ulcerated. Not only plantar aspect, dorsal aspect, as well as the side of the. PowerPoint is not moving fastly. This is bilateral paronychia, toe gangrene. This is another ulcer which was shown by the surgeons. So they have applied rubber band. Rubber band caused gangrene at the tip of the toes, and rubber band applied to protect the wound from the dust and water. After good control of diabetes and maintaining the good control, wound is getting healed, and persistent good control helps the patient to get rid of the complications. So totally getting healed. So this is infection, cellulitis. Again, good control is getting healed, and Dr. Babla only managed this patient. So whole leg abscess opened and drained raw area, and by paying 3 lakhs before her daughter's marriage, her limb was saved. So again, this is huge ulcer. Again, managed in these two cases are managed in the Billroth Hospital only. So I think sensor. So these are all few photographs. Again, skin graft is helping. This is totally Charcot's joint, infected Charcot joint. No other go, she has to go for amputation, artificial limb. So these are all the other. So a lot of food problem we come across. See, this is toe gangrene. See, he is smoker, alcoholic, and uncontrolled diabetes. Whole foot is getting gangrenous. So no other go. He has to go for amputation. Smoker, alcoholic, and uncontrolled diabetes. So these poor patients also undergoing amputation, develop diabetes. So we are. This is. Sorry. Nachi. Go for full screen. So little toe as well as forefinger, both are amputated. And bilateral amputation. See, forefoot amputation, below knee amputation, and ring finger amputation. So multiple amputations. So future diabetics should avoid all these problems. Second toe, fourth toe amputation, toes amputated in both legs, below knee amputation, and after amputation not getting healed, amputation is a preventable economic burden. So the message is, we have to prevent diabetes. If not, keep the diabetes well under control. If not, identify complications early, and not to make the patient to struggle like this in the name of treatment. Unfortunately, they are coming for treatment, but they don't realize for what purpose they are undergoing treatment. No other go, we have to make them understand, realize for what purpose we are treating them, by making them to maintain the blood sugar well. Thank you.
Thank you, sir. Thank you so much. I request all the speakers to be on stage. I request Dr. Gunasekaran sir to felicitate the speaker. So please. I request Dr. Chakravarti sir and MS ma'am to be on stage. CAO Dr. Vasant sir and CBO Bharati ma'am, please be on stage. Thank you so much, sir. Sir is a pioneer of diabetes. Thank you, sir.
No, myself and Gunasekaran from same college, Tengalpet Medical College. Right, thank you.
Thank you, sir. Thank you so much, sir. Sir. I request. I request Dr. Senil sir to accept the felicitation. Thank you, sir. Thank you so much. Thank you, sir. Thank you. Thank you, sir. Done, sir. I request Dr. Pablo sir to accept the felicitation. I request Dr. Praveen to accept the felicitation. Thank you, sir. Thank you so much. I request Dr. Monica ma'am to accept the felicitation. Thank you, sir. I request Dr. Wasim sir to accept the felicitation. Thank you, sir. Thank you so much. Thank you all. Thank you, sir. Thank you so much.
So I profusely thank the entire Billroth Hospital team who made this platform, especially Dr. Bablo, to focus on diabetic foot from prevention to tertiary care of diabetic foot problem. Especially Billroth Hospital has all facility for prevention of diabetes to tackling the complications. Over to Billroth Hospital team. Thank you.
Thank you, sir. Thank you so much. Thank you very much for all the participants to patiently attending the CME session, which was prolonged a long time. Thank you. Thank you for all. Thanks for the organizing team. Thanks for the marketing team. Thanks for the IT wing. Thank you, everyone. Please join us for the dinner. Thank you. Thank you.
Every organ, every patient, every story is different. Fully automated and remote sensor. India's first modular flat panel cath lab with state-of-the-art technology. We redefine what's possible. FFR, IVUS, IVL, Rota Ablator. Experience care like nowhere else. Take care that heals in new ways. Patient outcomes like never before. 30+ years of beating in the heart of Chennai. Billroth Hospital, Shenoy Nagar, Aripuram.